My name is Ben Owens. I'm a clinical associate with ESIS and ED consultant at Sherwood Forest. Particularly interested in balancing risk in emergency care. We've been asked to share with you a presentation we've done a few times on that topic, but actually giving you the slides, and this is just a short video to talk through how to talk about the slides, so you can utilise that within your own organisations if you want to have these conversations with your own staff as how we can do this, because this is a tricky topic and it's things that staff aren't always trained to think about or do, and it's trying to think how we can do this better for our patients. So I'm going to talk about slide 1 first, which is just an opening slide, and the title of Balancing Risk, Empowering Patients in Emergency Care is because there is no, the emphasis made here is there isn't a right or wrong in this sometimes, and actually you have to make different decisions depending on the risk that's occurring in different situations. So at the moment we see people stuck in corridors in ED or prolonged time in ED. We also see people, and the other photo of ambulances outside the EDs, actually prolonged ambulance rates is a particular risk at the moment for patients in the system, mainly, most importantly, the people outside the system. And if we don't do something differently, we're not going to get a different outcome for our patients, but also for our staff, because it's a very difficult situation to work in. So that's the emphasis from the first slide. Going to slide 2, there are 4 things. So it's really emphasis who can be harmed when a patient is admitted unnecessarily or staying in hospital longer than necessary. These are people who either get admitted who don't need it, or people who stay in a bed longer than they need to. The blue figure on the right represents that 4 people are harmed. The blue figure on the right represents the patient in the hospital who doesn't need to be there, who doesn't benefit from that treatment, but is at risk of non-scopal infection, deconditioning, in some occasions ultimately death, or never going back to their own home again. They get stuck and end up in a care placement because of deconditioning. The second patient who can't get into that bed is the patient in the corridor, stuck in the ED for a prolonged period of time. We know there's a high mortality past 6 hours, and we know there's significant risk of that. With some hospitals now up to 40 hours. We then talk about the ambulance patient stuck outside the ED. The ambulance patient outside the ED is not getting the care they need and will often get stiffer and more sick whilst in the ambulance outside the ED. But most importantly, as you go further left, there's a person stuck in the community, in the house, having no hospital care whatsoever. We have unfortunately had people die in the community waiting for ambulances while they've been stuck outside EDs. So actually the emphasis is if you have one patient in a bed that doesn't need to be there, up to 4 people are harmed, and some of those harms will be fatal. So that's the compelling case to change, really. Unless we do something differently, we will potentially cause harm. And at very best, these patients get a poor experience. At worst, significant harm. A quick emphasis on what hospital admissions are for. On slide 3, we're looking at the intensive care bed represents the patient who is very unstable, needs to be looked after because they're at high risk of deterioration or death if they don't stay in. And the second, then the operating theatre side is really about patients who are having a treatment that must be given in hospital. It doesn't have to be surgery, but the question is clearly if it can only be given in a hospital environment, then actually everyone else does not need benefit necessarily from being in a hospital bed. And that's the thing about that slide. So no one would argue with that. Slide 4. This is just an issue. Obviously, there is a valid consideration from staff around social care, and a lack of social care beds is causing a backlog of patients. So why should we change our behaviour because of a lack of social care beds? Well, the reality is there are no more doctors out there, there are no more nurses out there are no more beds out there, and there are no more social care staff out there. So no matter how much we may want that to be part of the solution to the problem, they're not. There are long-term fixes, some of them very long-term fixes, but that's not going to change in the short term. So relying on that as a reason not to change our own behaviour is neither realistic or right for patients. But we have to come to terms with that, and that's the emphasis of that slide. Slide 5 is just about alternatives. There are lots of alternatives now available for hospital treatment. But the reason for the pictures is the question is, why is the bed deemed to be safer than the chair in the ambulatory care unit? And of course, there is no rationale for that. Is that they're covered by the same the emphasis here, they're covered by the same cardiac arrest team, they're covered by the same thing, they're in the same hospital footprint, and therefore why is that bed, for 90% of patients, why is that bed seen to be safer? Because people say ambulatory care is risky somehow. So the alternatives being SDEC, hot clinics, community services. Virtual wards are new, but every trust now has them because of COVID. 2-week wait clinic for cancer, so So most people who have coronary cancer are dealt with through 2-week waits. Sometimes they're kept in hospital when actually it could be referred to that. There's primary care services and community services that can deal with people like community fast responses. And there's good old-fashioned safety netting, go home and come back if you feel more poorly. But there are lots of alternatives out there, and actually they're well established, and in some organisations they're used very routinely, so it's trying to get everyone to utilise those for the best thing for the patient. Slide 6 is just a cartoon. It says she's not safe, and it's about our language we use. So if we talk about it's not safe to do whatever it is, not safe to mobilise a patient, with the obvious example here, it might be not safe to send that patient home. Actually, there is no concept. Not safe doesn't exist. It's actually a combination of balancing risk. So the only way to permanently reduce your risk of falling is to never stand up and walk again. And that's not even sitting in a chair, because you can fall out of a chair. It's to lie on the floor, and clearly there's huge risk of pressure sores, deconditioning, and a number of other things, never mind quality of life impacts and life expectancy. So, but someone would say someone is not safe to walk, like maybe they're not safe to lie still as well. So it's that thing of, it's not about not safe, it's about a balance of risks. It's safer, less safe, but you cannot eliminate risk. And the point of this slide is really that. Slide 7 is an example of falls, picking up on that. So falls are a common reason people are kept in hospital. So actually, it's just some stats on falls. So you can't eliminate falls. Falls prevention doesn't exist. You can have falls reduction, but you can't prevent them. So 30% of those over 65 will fall. 4% over 80 will fall. And just go through the stats there. The main emphasis this is that falls increase in hospital. They don't go down. They're in a strange environment with things that are further apart. They're not in their own homes, so actually they're more likely to fall. And if you fall in hospital, you have a higher hip fracture rate, which is not surprising, because you're going to hit a concrete floor. You're not going to hit a carpeted floor or grab something on the way down. You might hit a concrete fall. And actually, so when you hospitalise someone who's a falls risk, you increase their falls risk further, and you increase their risk of fracturing when they fall. So you're not making them safer in just falls risk being the reason to be in hospital. Slide 8 is about behaviour. So there are behaviours that we do that can cause harm to patients. So unnecessary admissions we've covered off, delayed discharges, exactly the same thing. Some of the phrases we use, so home if blood's normal. So someone who's getting recovering inflammatory markers, renal function, liver function, whatever it might be, they don't have to be normal before they go home. They just have to be getting better. So actually expecting things to be normal before they go is not necessarily there, because staying in hospital is a risk in itself. The reassurogram bit is about a test you do to make yourself feel better. So it's doing the CT head to prove that they haven't got a head injury you never believed they had, doing a chest x-ray to prove the pneumonia is resolved, even though the oxygen levels are normal and the patient feels well. There's also refusals to change ways of working. So hot weeks, review people for other specialties. In terms of bed management, boarding patients sitting out discharged now, they may all be appropriate at certain times. Organisations that won't offload ambulances clearly cause an impact down the system to the ambulance patient and others. And the OT-PT reflex is about everyone is over 65 needs a therapy review. They clearly don't. There are plenty of people who don't need that. And it's using examples from your own hospital of patients that have been kept in for therapy review whilst they're walking around the ward. So why do they need that review? Does it really need to happen in hospital? Slide 9 is about language. Well, the language we use is really, really important. So things like when you hear clinicians, and we've done this ourselves, say, I'm not happy for you to go home, in that I'm talking about I'm not happy for you to go home. I'm talking about my own happiness, not what matters to the patient. So actually what matters to the patient. Things like, but they might fall. Well, yes, they might fall, but we all might fall. So unless they stand up and fall over immediately, they clearly can't walk at all, then actually falling is an established risk that patients take all the time. The not safe thing is also there, as we talked about before. Not safe doesn't exist. There's a risk in it all. If I say I'm not happy to sign him off on the stairs, I'm talking my own happiness there. It's their choice, it's their risk. I'm not risking my PIN on my registration, is a phrase we hear used sometimes. That's you never risk it if you document properly. You never risk it. The relatives might complain. Well, a complaint that's given for the right reason it's not a complaint to worry about. If we never get any complaints, we're probably not pushing things hard enough. It's not to say complaints are good. It's about having a conversation with people. I've done this myself many times. Got people out of hospital who didn't want to be discharged initially. I've never had a complaint over it. So if you have that conversation in the right supportive way, you can do these things without getting complaints. But fear of a complaint should not be a reason not to do the right thing. Slide 10. It's about drivers for this stuff. So actually, people believe they're only responsible for the patients in front of them, my patients. They might say I'm not responsible for ED or ambulances, but obviously then there's a knock-on effect to what we do. Commonly for these things by particularly doctors, I might be sued. Well, the reality is it's almost impossible to be sued as a doctor when you analyse it properly as an inpatient. We've checked with the MPS on this. You might be called to the coroner. Well, coroner's cases, I use the example of my own trust, use your own. We have 150,000 ED attends and 30,000 admissions, and we have about between 10 and 20 coroner's cases a year. And even if you are called to the coroner, those that result in sort of criticism of the doctor involved is in the 1 or 2 a year. So if there's 200 consultants in a hospital and there's 2 cases a year that cause a problem, you've got a 1 in 100 chance of going to the coroner over a case. So actually, it's just putting those risks into context. It's about not my job. Well, it's always our job to do things. And what we measure, if you measure negative things like falls and infection control rates, you will get negative behaviour. When actually, if you measure balancing measures like mobilisation rates, then actually you can make a difference in that. The next slide is just about measuring falls and actually saying a good example is getting people to actually, if you're in a room with them, getting them to get them to sit on their chair, fold their arms across their chest, and ask them to stand up. And that most people will do that happily. If you then get them to put their feet forward so their knees are their front of their their back of their heels is in front of their knees, and you get them to stand up again, it's very difficult. What that equates to is equivalent of about 10% muscle mass loss. And the point to make there is if you're in a hospital bed for more about a week, you can have a 10% muscle mass loss. So if the end point you make to staff is if it's difficult for us to stand up with a 10% muscle mass or power loss, then actually how does it feel to an old person who's 100% is walk across the room with a frame? So just a week in hospital can make someone hospital bound is the point we're making here, and then make it feel real to the staff. Talking about risk of death, we worry about death hugely for the elderly. Point of slide 11, but actually 45% of people over 85 die within 1 year of hospital admission, and the frail elderly don't usually fear death, they fear loss of independence. Well, we worry about them going home and dying. If you ask them what matters to them, they often talk about independence loss. So it's that conversation with your patients about what matters to them. Slide 13 is about real risks. So if you're admitted to a crowded ED, you have a 43% mortality increase if you're admitted for 10 days or more. The last 1,000 days bit, if you're over 77, you've got 1,000 days of life left approximately. How many would you choose to have in hospital? So it's emphasising the point of we're actually depriving people potentially of the last days of their life spending in their own home. And obviously bed rest and muscle mass loss, we talked about that already. The next slide 14 is about logic, about what we can't afford to do some of this stuff. Well, the single most expensive thing to do with the patient is put them in an ambulance and drive them to hospital and keep them there. It's very expensive doing that. So actually that's the first thing. So it is more cost effective to manage people differently. Again, hospital buildings for the sick people, and keeping them in, admitting people unnecessarily and keeping them in is a risk to each patient and also to others, as we mentioned earlier. And therefore, it's emphasising the point of getting people home is the best thing for patients and for the system, and the most cost-effective thing too. Slide 15 is about the real risk. So actually, when you speak to staff and dig underneath it a bit, it's about the perceived risk to the staff. What will happen if they go home? Will I go to the coroner? Will I be sued? Will I lose my registration? Will the relatives complain? And actually, we talk about the actual realities of that. If you talk about the emphasis on this slide is really about what the patient risks. They risk loss of life, loss of independence, loss of time, which is precious when you're elderly and frail, loss of all those things. When actually what we risk as clinicians, if you document stuff, is very, very little, if almost none. So it's emphasis about putting that into context for the staff. The slide 16 is a hotel room. The reason the hotel room is there is really to emphasise what it's like to be in hospital. So the emphasis in this one is a lovely hotel room. How nice is it when you've been on holiday for a week in a lovely hotel to get back home into your own bed and go, oh, I'm in my own bed. And the emphasis in this slide is really for the next slide, which sets up, and that is you've got 1,000 days left to live. We're now going to TripAdvisor the hospital. You can insert, this is my hospital on here, but you can insert your own hospital as a picture. But actually, here you talk about, let's rate the accommodation. I shared a room with 4 people I don't know. Let's rate the, how many stars would you give that? Bathroom facilities. At best, I share a bathroom with 4 people I don't know. At worst, I have to go to the toilet in a cardboard bedpan behind a curtain when everyone's listening to me. Food, they serve me food that's all right, but it's not what I wanted. It wouldn't be what I choose. So none of us would stay in that hotel with 1,000 days left to live. So no matter how wonderful our hospital might be, it's not a great place to spend time if you can avoid it. So that's the quality bit there. Slide 18 is a slide of 2 operations, and that is really just to talk about. One is a big full-blown on the left-hand side laparotomy. On the right, it is a laparoscopic, and you say this both appendix can be taken out in both these ways. No one does the appendix in the open way anymore unless it's a really and they've a massive perforation. And so, why do we challenge? The question is, why do we see process and behaviour differently in clinical treatment? The point of this really is around. If you have a patient that's got, if you were a patient, would you choose a laparotomy or laparoscopic? And you say, well, I'll choose laparoscopic, obviously. Why? Less pain, home quicker, smaller scars. Then you ask the next question, which one is more difficult for the doctor and the hospital to do, the theatre staff to do? The laparoscopic one's more difficult for the doctor and theatre staff to do. So actually the point here is no one would allow a surgeon to do an open midline full laparotomy incision for an appendectomy over a laparoscopic one, even though it's more hassle for them, because it's better for the patient and the patient discharged quicker, so better for the system. So if that's the case with surgery, why do we not challenge that with other kinds of behaviours such as ward rounds, admissions, board rounds? People don't do things in the optimal way. Why do we not challenge that kind of behaviour? And that's something we can encourage people to do. Phrases you may want to challenge or stop using. I'm risk averse. Well, actually, risk averse normally shifts. The point there is risk averse shifts risk somewhere else. It doesn't eliminate it at all. We can't make things safe or no risk. It's always shifting the risk somewhere else. People who've got my risk or I'm not taking the risk, they talk about themselves, not the patient. The phrase back to baseline is a phrase we shouldn't really use in healthcare. The emphasis I always use is I had an arthroscopy on my knee and cartilage taken out of my knee, I think 6 years ago. I'm still not back to baseline. I still can't jog downhill without my knee swelling up. I've been home since the day I had the operation. So actually back to baseline is something it sets a false expectation for staff and patients. Well enough to go home is different to back to baseline. Medically fit for discharge, same things. Medically optimized, deficit, medically fit can put a false expectation, particularly around social care. They have to be off antibiotics for their UTI rather than they're just off their delirium and on their antibiotics continuing for their UTI. Could go home on the antibiotics. Not safe. We talked about failed physio, failed stairs assessment. The emphasis you put on that is if the patient hears they have failed, they're much less motivated to do something. And other phrases along that slide as well we talked about earlier. Slide 20 is a picture, is about neck of femurs, and this is just to use the example of how daft risk management in hospitals is. So you give the example of, and this will apply to someone in your hospital. If you have a patient that comes in who hasn't had a fall but is very unsteady in their feet, they're doing a falls risk. They're often kept relatively chair or bed bound for most of the time they're in hospital. If after 3 or 4, and they haven't mobilised much at all, after 3 or 4 days they fall and they break their hip on a hospital concrete floor, day 1 post-op, they will be mobilised every single day by a therapist, even though they've just fallen. So their falls risk is higher than when they came in because they hadn't fallen when they came in. But also, if they do fall, they've now got metalwork in their hip and an open wound, a wound on their leg that's closed. If they fall again, they split that wound or fracture, the operation is even more dangerous, but we still mobilise every day because it's better. And the really daft thing is if they fall and they don't break their hip on day 4 or 5, then they're even more kept in beds and chairs, where if they fall and they will be mobilised every day. Just an example of how daft we are in the NHS at managing this, and that will apply to patients in your own hospital. This is about empowering patients parts. The first part about risk, the second part's about empowering patients. So if they've got dementia, people say, well, I can't ask the patient. Well, actually, you can ask the relatives. Don't ask the relatives what they want. Our obligation is to the patient. And asking that, what we should do is ask the patient relative, if the patient can rewind 20 years and stand at the end of the bed and see themselves now, what would they want us to do? It puts the patient back in the centre of the discussion here, which you can do with someone who's awake and not confused, but with someone with dementia, that's the way to ask the question, not ask the relatives what they want. The next slide is about, slide 22 is about what we can learn from elective care. Well, actually, if a patient can consent for a bypass and they can decline a bypass, even though it may increase their risk of death, for example, and we absolutely allow that, and we just document why they decline that bypass, why do we not talk about that for admission or discharge? Why do we not give the patient the choice rather than telling them what we think? In surgery, as an example, elective care, we accept any risk the patient wants to take, document it in the notes. Why don't we do that in emergency care? Why do we not give them the choice? Someone can consent for a bypass, and a really example, they can't consent whether they can climb the stairs safely or not, even if they may want to. And that doesn't make any sense, and none of us will probably accept that. This form here is just a consent form someone wrote up, which you may or may want to use. An ED consultant, Simon McCormack, drew this up. Basically, it is about a consent form for admission. So admission to hospital is safe for going home. The emphasis here is obviously intended benefits, early investigations, not falling, having time to arrange social circumstances and care. The serious occurring risk is a long list. So loss of confidence, loss of muscle power, loss of mobility, loss of sleep, increased confusion, increased risk of falling, increased risk of hospital-acquired infection. And the last one I always tend to emphasise really clearly, not getting back to your own home ever. And that can be either through death or because they decondition to a point, or people are so scared to send them home that they end up in a care home. So that's what that is, emphasis on that is. The empowering patient thing is actually what the pros and cons of remaining in hospital and admission, asking the patient what matters to them, independence versus loss of life versus what doesn't matter with them. And there's movements out there all around this, but document. This is the patient example I use. This example I encourage you to use your own. This is my father-in-law, and the case example I use with him is that he it was very fit, independent. You see him on the left-hand side. He now has Parkinson's, and I tend to tell the story and introduce the fact he's my father-in-law at the end. I actually say he was admitted to hospital. He had a clear care plan, not for hospital admission. He'd fallen over and split his head open, and needed that suturing up. So he was taken in for that. During which time he had a postural drop with his Parkinson's, but also had he's got a cardiomyopathy, so someone does troponin, which was mildly raised. It took 10 hours of convincing by myself, my wife, and my mother-in-law to get him back out of hospital because people were worried that he had to be admitted because he had to have an assessment for his heart, and actually he was not for rhesus, not for anything else, and he's at home 4 months later, absolutely fine. No, if he didn't kept in, his Parkinson's is so constrained by time. If he misses a dose by 10 minutes, he's frozen for hours. So actually, if someone's as engaged in the system as we are can struggle like that, how is it for other people? But use your own example for that and make it personal. It's much more powerful. Slide 26 is about risk and safety. Basically emphasising this risk in whatever we do is risk in all the outcomes. A bit about autonomy. We all want individually want autonomy. We often want safety for our relatives and our family. Well, actually, they deserve autonomy too. And that risk-averse decision-making for one person increases or moves that risk elsewhere, and it belongs to the patient. So emphasising the patient risk. This is a slide about balancing risk. There is no safe or not safe, but it's really about balance, and that will change depending on what's going on around you. This is just a slide 28. It's about ownership and system view. Every decision we make about a patient is a risk to them, but also has an effect on others, and re-emphasising the for patient harm there. And how we check examples from life bit at the bottom is about how we change our behaviour in community with litter, with recycling, with car emissions. We all do that, even though it may not directly affect us. We do it because it's the right thing to do. It's socially acceptable. And the point there is about if we change how we do this as a hospital, as a healthcare system, then actually we can make it socially acceptable to do these, to not talk to patients, to admit people who don't need admitting, and we can change this. And all these things like litter and cycling, car emissions, drink driving shows that we can change these things through behaviour. Slide 29 is about how to change this, encouraging staff to change the language, change the perceptions, talk about risks of being admitted or staying in, and actually giving the patient the risk and empowering them and giving them the decision to what they need. Slide 30 is just an example of other things like this you can share with staff. I'm happy to share that. It's a link which they can click onto, and the timing there is when the presentation is, if they want to use that. Slide 31 is the 4 questions. So talking about every patient should know, and no one would argue with this, and you can introduce this in your organisation. What's wrong with me being excluded? What's going to happen today, tomorrow to get things out of the plan? What do I need to achieve to get home? If you set the criteria of what people need to achieve, mobilising the bathroom, being off oxygen, they're much more likely to achieve it if you don't tell them. And if the recovery is ideal and there's no unnecessary waiting, when should I expect to go home? So the expected date of discharge. And this is about getting families and patients ready to go, and rather than tell them on the day, because it's much harder to get people home sometimes in that scenario. Slide 32 is the criteria to admit tool, and actually that's just there to visualize the share as a tool you can use, and there's separate videos on that. Slide 33 is about brand tool for decision making. This is about choosing wisely UK, and the emphasis here is supported by all the Academy of Royal Colleges. It's a thing to use both for documentation but also for conversation with patients. So brand means what are the benefits, what are the risks, what are the alternatives, what if I do nothing. If you talk that through the patient and if you document it, your trust solicitors will tell you if you documented that discussion in that way, then actually you're medically, legally completely covered, whatever the patient decides to do. The next slide is 34, is the inpatient decision support tool, which is a tool that can take people through processes to try and change or nudge staff to influence decision making. There were separate videos on that. 35 is about talking about what we can do differently. So actually, what can you do? You can talk to your teams about balancing risk and ownership. It's emphasizing the points again. So alternatives to admission, 4 questions, brand decision making tool, and decision tool for the ward. Go and do an audit, go and talk to your teams, walk the wards, ask the questions, and there are things we can do differently. And slide 36 is a finished slide. You can use it if you want, or you can use your own example. The Albert Einstein quote, if we don't do something differently, we're not going to get different results. And the emphasis really, if we don't change our threshold for risk, some of our patients will risk anything. And by that, obviously, a small number risk their lives, some risk not going home. I hope that made sense. We'll send the slides out to go with this video. And other than that, we're happy to receive feedback as well. Thank you very much for listening.